Welcome to Ask Dr. Mingle, the Q&A series from Mingle Health, answering your questions about quality programs and the transition to value-based care. I'm Kyle Breckel. I'm the digital marketing specialist here at Mingle Health, and I'll be hosting this episode along with Dr. Dan Mingle, founder and CEO of Mingle Health. Good morning, Dr. Mingle.
Good morning, Kyle, and good day to all of you tuning in. It's great to see you again. I'm Dr. Dan Mingle, and I'm here to answer your questions to the best of my ability.
So we have one question today from Keith, and Keith sent us his question via email to hello@minglehealth.com. Just a quick reminder, you can always send us an email with your questions, or you can leave your questions for Dr. Mingle in a YouTube comment or a LinkedIn comment as well. So Keith asks, I am a solo ophthalmologist who still uses paper charts. I have received exemption from MIPS for the past few years, but I expect that will not be available to me in 2024. My goal is to spend the least amount of time and effort on MIPS in order to minimize my penalty. The staff at Mingle has suggested I submit an EMA cluster, which seems too good to be true. Could you provide a bit more explanation on this option?
Great question, Keith. Yes, it does seem a bit too good to be true. And in the context of this, first I'm going to specifically answer your question about EMA, and then I'll put it into the context of your MIPS submission by specifically dissecting your possible submission dynamics. First, EMA stands for Eligible Measure Applicability. To explain, many specialists have difficulty finding 6 measures that are both measurable and applicable to them. There's a lot of variation in scope of practice in the United States healthcare practices. That is to say, there's not a lot of standardization around specialty. Now, Medicare does not want to be in the business of evaluating each provider's or practice's individual measure applicability and choices. So Medicare's created a couple of simple automated rules that provide what they think is good enough for now assessment of measure applicability. The EMA, or Eligible Measure Applicability category, is one of the methods. Specialty measure sets is the other. Now, the principle behind EMA clusters is that they are measures that are clinically related. Medicare assumes that if you submit one measure in a cluster, you should be able to submit all of the measures in the cluster. Now, if you submit 6 measures, the basic requirement, Medicare is going to score them. Other than denominator specifications and measure completeness criteria, there are no prerequisite requirements to be eligible to submit any measure. Any specialty, no matter what you're doing, you can submit any 6 measures. Medicare is going to score you on them. Now, if you submit fewer than 6 measures, Medicare will look for EMA clusters and specialty measure sets. If your submission contains fewer than 6 measures, but all of an EMA cluster or all of a specialty measure set. Now, most specialty measure sets have more than 6 measures. So that doesn't help you at all. But if your specialty measure set has fewer than 6 measures, a complete submission of that measure set is fully scored. You don't get penalized for missing measures in those cases. Your perfect score is reset to 10 times the number of measures in the applicable set. In this case, the internal eye care EMA cluster has 3 measures: 141, open angle glaucoma, and measures 384 and 385 regarding retinal detachment surgery. Now, this is an interesting and slightly unusual cluster, where it's relatively common that an ophthalmologist dealing with open angle glaucoma does not also do retinal detachment surgery. So to pass this EMA cluster, you have to submit all 3 measures. But Medicare does accept a shorthand to signal that you don't do retinal detachment surgery in this reporting year. If you have no retinal detachment surgery, you will have no patients qualifying in the denominator. You will report a 0 denominator. Medicare will forgive the absence of a calculable score for the 2 retinal measures. Your 6 measurement requirement will go down to 3 with the use of the internal eye care EMA cluster. Your 3 measure requirement will go down to 1 with 0 denominators in the 2 retinal surgery measures. Medicare won't score those 2 measures. They'll forgive their absence and give you a full score based on 1 measure. So whatever your score on that measure is, be it great or poor, that's going to be your score for quality. Now, not all EMA clusters act this way. Procedure-related measures most often do. Measurements of eligibility is generally clean and clear with procedure measures. If you've done the procedure, you build the procedure, and you're going to have eligible patients. Strictly following denominator specifications in eligibility ends up being clear. Other measures, not so much. Many measures where eligibility is based on E&M codes and ICD-10 codes, you can have denominator eligible patients even if you don't provide the care. Zero denominators are generally not found. To enjoy a similar dynamic that I just described, you would have to submit your best data, then request a focused review on what you expect to be a poorly performing measures. I have no great confidence that Medicare is going to accept that argument, but you should do it. At least it's going to register your objection to the scoring methodology and add to Medicare's perception that there's just not enough measures for many specialties. So thanks, Keith, for the great question about EMA clusters. I think it might be also informative for you and our other viewers to dissect all the possible dynamics of this particular submission. Your needs fall within 3 of Medicare's priority concerns, creating a solid path for you to at least minimize your penalty and possibly avoid it altogether. Medicare's concerns: first, small practices. Medicare is aware that MIPS could have an outsized negative impact on small practices compared to larger ones with more resources. So there are extra protections for small practices, such as automatic exceptions for promoting interoperability performance category and favorable dynamics for scoring quality measures. Second, there's a shortage of specialty measures. Medicare is aware that many specialists have difficulty finding applicable measures. So there are a couple of opportunities to permit full scoring of abbreviated measure sets. And third, Medicare is aware that there is a wide variation in scope of practice that is not fully explained by specialty designation. So they've created a couple of simple automated rules that provide what they consider good enough for now assessment of measure applicability. Eligible measure applicability is one of those methods, which I explained earlier, and specialty measure groups is the other. So what does all this mean specifically for you and your submission? First, you get an automatic small practice exception to the promoting interoperability performance category for now. For the foreseeable future, you are excused from the requirement to use electronic medical records. Unless you make a promoting interoperability performance category submission, the promoting interoperability performance category does not exist for you. Where your peers in larger groups are scored 30% on quality, 30% on cost, 15% on practice improvement, and 25% on promoting interoperability, if you take the exception for PI, that is promoting interoperability, quality for you is 40% of your score with 30% on cost and 30% on improvement activities. Now, second, you may not be subject to any cost measures. You're not primary care, so you're not subject to total per capita cost. You probably have no significant inpatient volume. In fact, I can't recall in my career ever seeing an ophthalmology focused inpatient. So you're not subject to Medicare spending per beneficiary. Now, there is an ophthalmology-focused cost measure on cataract removal. Medicare will measure that for you if you have at least 10 cataract extractions in the year. Now, if you don't have cost because you don't do cataract extractions and you don't have promoting interoperability, 50% of your MIPS score will be based on quality and 50% on practice improvement activities. Now, third, on quality, you have the EMA opportunity we described earlier, and you could use the ophthalmology specialty measure set. There are only 2 measures in that set. It's number 141, open angle glaucoma, and number 226, tobacco use screening and care. 226 is a hard measure because every patient qualifies for tobacco use screening and care, and it's generally not a focus of ophthalmology practices, even though it might make good sense for everybody to ask if you're smoking and suggest you see your primary care doctor if you are. The other problem with the ophthalmology measure set is that it only applies to Medicare claims submissions. And claims reporting is one of the most difficult reporting techniques to pull off. There are just a lot of potential failure points that I won't get to in this presentation. I've talked about it before, and I may focus on it again at some point. Also in quality, there's a small practice quality bonus, 5 points added to your score, however it's submitted. Now, it can't pull you above a perfect score, and so it can't make up for deficits elsewhere in your MIPS submission. And there's still a 3-point floor on any measure submitted, even if you report only one patient and or a 0 performance rate. Now, 3 out of 10 possible points is not great. It's better to use a small specialty measure set or an EMA cluster if one applies, but it can still protect you. 3 points is better than 0 if you otherwise can't escape the six measure requirement. Now, fourth, there's no escaping the need for practice improvement activities. Practice improvement activities is going to represent 15% or up to 50% of your score under any dynamics, except, like the COVID exceptions, qualifying for a complete exception to MIPS reporting. I suppose it's possible to apply for and receive a specific exception to improvement activities. I've never seen one, and if you've happened to have received one, I'd appreciate your dropping us a note and telling us the circumstances in which that happened for you. Now, small practices still get a break with improvement activities. They need half the activities that a larger practice requires. For a small practice, 2 medium weight or 1 high weight activity is enough to qualify you and get that full 15 or 50% practice improvement activity score. So I hope this has been helpful. I wish you easy and successful MIPS reporting.
Absolutely. And thank you for the excellent question, Keith. And thank you, Dr. Mingle, for sharing your insight with us today.
Thank you, Kyle, and thank you, Keith. Thanks, everyone, for all the great questions. I want to be helpful, and I want this to be useful to you. Don't hesitate to correct me, to supplement my answers, share your experience, ask your questions. We can be smarter together.